So our first learning objective is to identify the molecular targets of currently available and emerging treatments for the management of psoriatic arthritis. So Joel, can you briefly discuss the differences between the extracellular treatment targets and the intracellular treatment targets, and maybe a little bit of how we're using them in psoriatic arthritis?
Yeah, so I think for the small molecules or pills, we have the classic methotrexate, which is sort of a non-specific T-cell active drug. We have better understandings of MOAs of our newer therapies, tofacitinib, a JAK inhibitor, apremilast, a PDE4 inhibitor. And then when it comes to biologics, of course, we have different classes of agents available to us. We have a TNF strategy. We have an IL-12/23 strategy, ustekinumab that is. And we have an IL-17 strategy. And time will tell whether or not we'll have a pure IL-23 strategy for psoriatic arthritis as we currently have in psoriasis.
Do you think these drug classes that are targeting specific molecules have any difference among the members of the class that we can put to use in individual patients? Jennifer, how about your thoughts on that?
Yes. So even within the drug classes, there are different rates of psoriasis clearance. I think overall, in terms of arthritis, the ACR20 scores are pretty much standard throughout. They all do hit that goal. But in terms of small differences, there are small differences that are there.
Mm-hmm. I think certainly dosing schedule is different also within class and between classes. So, if you're a patient who's a needle phobe who needs to be on TNF inhibitor, you might think about a certolizumab, which could be dosed monthly, for example, compared to, say, a etanercept that's to be dosed weekly. Or perhaps if their joint disease is not too significant, you might consider an IL-12/23 inhibitor, which could be dosed every 12 weeks.
So given that we have these treatments with multiple mechanisms of action right now, do you think we need more, Jennifer?
Always, right? More is better. No, right now I think it's a really exciting time. I mean, I think as a young rheumatologist, we'd always thought of psoriatic arthritis just as a younger cousin of rheumatoid arthritis, but now it's really emerging as its own real entity with different treatment options that are available. And I think that given the lack of durability necessarily of these medications, we will need more and more agents for patients in the future, especially younger patients that are starting with treatment earlier.
Yeah. I think it's important to have perspective on this. When the TNF inhibitors came out for psoriatic disease about 15 years ago, a lot of us felt, wow, this disease is going to be so easy to treat now. Therapies that work well or well tolerated, and then quickly learned over time that people lose response to that drug or don't respond at all. I think we're fortunate in the skin space that we probably have really honed on to the cytokines that are fundamental to the pathogenesis of disease. The IL-17 inhibitors, IL-23 inhibitors, those pathways seem to be uniquely important for mucosal or barrier immunity, be that in the skin, the lungs, or the gut. And so the advantage of that in psoriasis is that you see very high levels of clearance. And also, they likely end up being safer because they're involved in a more specific way of immune modulation. They do have a specific side effect, more susceptibility to yeast infections or candidal infections. These still occur infrequently, around 5% or fewer patients, and usually respond to topical therapy, over-the-counter therapy, so rarely a cause for stopping treatment. That being said, I think the ACR20s are still not great. We'd like to be able to see ACR70s approaching 90% before you knew you had a MOA that was definitely being useful for all patients with the disease. So we have a lot of progress to make.
So I'm not suggesting in this next question that we should, but do you think in the future there may be a role for combining the various agents that we have in either psoriasis or psoriatic arthritis, whether it's full or partial dose, as we begin to learn more about mechanisms of action and cell pathway interactions? What do you think?
I think we need some more real-world data on this topic, because we all know as clinicians how each individual patient's journey is unique. And so a lot of us have patients who say their joints have done well with their TNF inhibitor, but their skin is not doing great, and maybe I guess adding a little bit of a whiff of an IL-17 every 3 months, maybe that would really make a big difference for them. So these are some unanswered questions that we need to make progress on for our patients.
Yeah, I already know of colleagues that will say, well, they use A to treat the psoriasis and B to treat the arthritis, and I marvel at how much time they may be spending on the phone with managed cost company C to get approval for both of them. But obviously something we need to look forward to. Jennifer, when do you decide that whatever you're giving isn't working well enough, however you determine that, and when do you switch?
Even though we have so many agents, I think we should be cognizant of the fact that there are still a limited amount of agents that we can use for our patients. So the question you should ask is the patient really not responding, or have we just not given it enough time? So I think a general rule of thumb for me is 12 weeks. So I'll give patients kind of 12 weeks to see if they'll really respond at all, or if they have a partial response that also provides significant information, and then move on from there.
Joel, what do you think? Do you think that the skin may be as heterogeneous an organ as the joints are, and just as we have large joints and small joints, you have skin in one area and skin in another, and that may necessitate different treatment approaches depending upon location?
You know, that's a great question, and you would think intuitively that should be the case. We know that psoriasis is driven by skin-homing T cells, tissue-resident T cells, as I say. That's the reason why people have the same plaque come back in the same area, for years. Because those specified T-resident T cells, tissue-resident T cells. Now that being said, generally speaking, the efficacy that we see, say, in the scalp, areas traditionally difficult to treat, the scalp, the palms and soles, tends to track with what we see in the overall response rate in patients for their overall skin. We have less data on inverse disease. There was one study of ixekizumab for genital psoriasis, which is a big advance in the field, the first study of localized genital psoriasis showing benefit there. It still becomes much a clinical impression and an individual patient experience to see which one is going to work for the tougher areas to treat. And the palms and soles is an area where we're really lagging the most. Very disabling for patients. Often people can't work or have trouble walking because of difficulty with those areas of involvement. If it's pustular in nature, those are especially difficult to manage.
Jen, do you have any favorite agents that you use depending upon the phenotype of disease as it's being expressed to you?
No, some of that is out of my hands. So some of that is managed care, unfortunately. Even if I were to have a favorite, I may not be able to use it. But I think in general, we generally start with the TNFs, right? So if you're talking about a biologic agent, we'll start with the oral small molecules first, meaning methotrexate or maybe even leflunomide, which has some psoriatic trials from a long time ago. And then usually it would start with the TNFs.
Well, thank you. I think we've given our listeners and viewers an opportunity to snack a bit and hopefully gain some insights from our brief discussion.